Welcome to the fourth session of the maintrac online forum for this year 2024. This is in English. You know Professor Pachman very well. She continues to lead the charges in the laboratory Pachman, both clinically and from a research point of view. And today we have the topic of the clinical question for maintrac and stemtrac. We'll start off with a presentation.
Thank you very much, Joachim. We decided for this last presentation this year to talk about frequently asked questions and try to answer them. One of the frequently asked questions is, what is maintrac? Maintrac is a diagnostic method, and it's highly sensitive to detect circulating epithelial tumor cells. That's why we call them CETCs, but we add CTCs because this is the most frequently used term in the English-speaking countries. What we do is to monitor the course of disease, of cancer, with the help of a blood test. And we can also monitor the response to therapy. What are the possible applications of maintrac? Maintrac can be counted among the liquid biopsies. So it's directly from the blood. Therefore, it can be repeated as often as necessary and do in first line maintrac cell counting. So we count the number of cells over time. But in addition, we can also test therapeutic substances on the cells directly. And in some cases, it's necessary to know the characteristics of the tumor cells for therapy design. That's our therapy relevant tumor characteristics. And finally, we can also test for cells that are capable of dividing in vitro and forming tumor spheres. Often the question is what type of cancer we can use the maintrac cell test for. It is primarily used for solid epithelial tumors such as breast, lung, colorectal, prostate, pancreatic or ovarian cancer. With certain limitations, it can also be used for other types of cancer, like melanomas, sarcomas, and gliomas, but this is with restriction because not all of the cells in such tumors carry the epithelial antigen. We rely on the epithelial antigen to find the cells. When can the counting be applied? So this is mainly thought for monitoring the disease during the course of disease. Then we can assess the effectiveness of ongoing treatments, and we can assess the risk of recurrence after the end of treatment. So it provides a valuable tool for insights for personalized cancer treatment. The next question is, how often should maintrac cell counting be performed? We can count the cells before treatment to establish a baseline for comparison and initial base value. Then the numbers of cells during treatment can be counted, and this tells us about the effectiveness of the ongoing therapy. It means if the cell numbers decrease, then this is a sign that the current therapy is effective. And if the cell numbers increase, then adjustments may be necessary of the treatment. After treatment, many patients are afraid of recurrence, and we can see early after the completion of the treatment that the cell numbers re-increase, and this would be a sign that possibly the treatment should be started again or a new treatment started. In case of progression of the tumor and the resistance, we can evaluate how the tumor is responding to new treatments, or if the cell numbers do not respond, do not decrease, we can early detect the hint for resistance. What are the benefits of this cell counting? As I mentioned just before, the recurrences can be early detected, because if the cell numbers increase more than twofold, there's a high probability of recurrence of the cancer, even before clinical symptoms become apparent. We can monitor, as I also mentioned, the treatment, and the count, maintrac count, can indicate whether an ongoing treatment is effective. And this would require regular monitoring of the number of circulating tumor cells over the course of treatment. And as very important, this whole test is minimally invasive. It's a simple blood test, and the procedure is much less burdensome than a conventional biopsy. Also, it detects cells, and thus is a sort of biopsy. Very often we are asked whether there is a threshold for the circulating tumor cells. But since each patient is unique and each tumor has individual characteristics, there is no universally applicable reference value. So each case should be analyzed individually, the cells counted repeatedly, taking into account the specific medical history of the patient. And when interpreting these results, the dynamics of changes in the number of circulating tumor cells is much more important than a single measurement. We then, in our reports, interpret the number of CET-CTCs. And as you can see, that's how it is represented in our report. There is the number of EpCAM positive cells in the sample, which is 1 ml. And then it's calculated for 5 liters of blood. And in addition, we give estimation of the cell fragments. But it's very difficult to give a number for the cell fragments, because one cell can decay into numerous small fragments. So we just give an estimation. And 50 is a minimal number of circulating tumor cells. 50 to 100 we call minimally to slightly elevated. 150 to 400 is slightly elevated. 450 to 550 we call slightly to moderately elevated cell numbers. And 600 to 1,000 is a moderately elevated number, and above it's a highly or significantly elevated number of circulating tumor cells. This is just that you get an impression in the range of cells that we detect. How can these changes in cell numbers over time be interpreted? So if the cell number decrease, like in this example, the removal of the liver metastasis by surgery led to a decrease. So this suggests that there is either a good response to treatment, or sometimes if it's extended, it indicates that the patient remains in complete remission. But in this case, cell numbers increased and a new liver metastasis was detected. And subsequently, the treatment led to a decrease in cell numbers, but the liver metastasis did not shrink, because sometimes the cell numbers decrease before the metastasis shrinks. Then under paclitaxel, there was a slight increase, but repeatedly. The metastasis was still in remission, but then a new liver metastasis was detected, and upon paclitaxel weekly again, cell numbers decreased, but this obviously did not reach the metastasis. And that's something which we frequently see that the cell numbers in blood are the first to respond. If, like here, an increase in cell count occurs, this suggests that the therapy is not effective or that the disease is progressing, and it may also point to resistance to the current treatment, as it is during the paclitaxel weekly, the initial one. Can we use maintrac as a screening method when there is no cancer present? We do at the moment not recommend maintrac routinely as a general cancer screening method. It is rather specifically employed for monitoring known tumor and the development of a known tumor, and it's not at the moment applicable for general early detection without any prior diagnosis. So this is in contrast to other methods which claim that they can detect a tumor early.